Good afternoon, everyone, and welcome. I am, as you heard, Mary Naylor, Director of the Robert Wood Johnson Foundation's Interdisciplinary Nursing Quality Research Initiative, or as we fondly call it, INQRI. As its name suggests, INQRI is a program that believes very strongly in the merits of interdisciplinary collaboration, something that begins and continues with our own leadership team. On behalf of that team, comprised of Mark Pauley, who has joined us today and who is co-director with me of this program, Lori Melikar, who is Senior Program Officer at the Robert Wood Johnson Foundation, and Heather Kelly, who is on maternity leave, and myself. I would like to welcome you to the final webinar in our series on dissemination and implementation of evidence-based practices. INQRI was launched by the Robert Wood Johnson Foundation in 2005, and the goals at that time were to generate, as you see on this slide, disseminate and translate research, all intended to improve the quality of patient care. We did this by focusing on investing in and supporting interdisciplinary teams of scholars to address major gaps in knowledge about the relationship between nursing and the quality of health care that they receive. In the next slide, you'll see some of the artistic interpretations of the work that we did during previous sessions. We've shared other versions of this. This piece we're sharing today is from a panel presentation held during our second annual INQRI meeting. This particular panel brought together journalists with editors and others to talk about all the possible venues for disseminating research findings. I remember it in particular because I think one of the panelists picked up a long précis or review of evidence that he had received, and he said, "This," and he threw it in the air and said, "This will not work." So we all remembered, for different reasons, panels, and this was a really special one that I think had a major impact on our grantees. So from the very beginning, we've been asking our grantees to focus on ensuring that their work is not only building and advancing new knowledge, but that it's designed to have a really strong impact on delivery of clinical practices, on relevant healthcare policies, on all the key stakeholders to whom knowledge is targeted. In addition to publishing findings in top journals, we want grantees to think about how it is that they can reach their multiple stakeholders, including patients, families, the public, about ways that they can craft their messages, tell their stories affected by their work. Today, you're going to be hearing from Nancy Hanrahan and Phyllis Solomon, who will be able to share some of the stories about those affected by their study on transitional care for people with serious mental illness. And in the next slide, you'll see that this is the last in a series of webinars on dissemination and translation. You can access the prior 5 sessions on our website, www.inqri.org, or on INQRI's YouTube channel. Following this session, we're going to be making this video available as soon as possible, and you will get a note out to you when it is available. So we hope that you'll take a look at our previous sessions, share the links with your colleagues, and also have a chance to review this session when you have time. On previous calls, we have given you the opportunity to learn about a very important group in the INQRI's program, and that's distinguished members of our National Advisory Committee. These are trusted partners from all walks of life who have committed themselves to work with us in improving health and health care for all Americans, and to ensure that nurses, as the largest group of health professionals, have their central role in this effort recognized. We brought them together once a year at our annual INQRI meeting. They had a chance, however, throughout the year to provide feedback, advice, encouragement to enhance our work. They've made themselves unbelievably available to our grantees, to advise our leadership teams, and to assist in dissemination efforts, and much, much more. Joining us today is one of our distinguished National Advisory Committee members. In just a moment, Jose Pagan will introduce you to Nancy Hanrahan, Phyllis Solomon, and their INQRI project. In the meantime, it's my honor to tell you a little bit about Jose. He is professor and chair of the Department of Health Management and Policy in the School of Public Health at the University of North Texas Health Science Center at Fort Worth. He's an adjunct senior faculty and fellow of the Leonard Davis Institute of Health Economics at the University of Pennsylvania. We have all of these Penn connections. He received his PhD in economics from the University of New Mexico. His own research centers on the effects of uninsurance and healthcare access and quality in local healthcare markets. He was a consultant on community uninsurance and healthcare quality for the 2009 report by the Institute of Medicine on the consequences of uninsurance. He was a Fulbright Scholar in Mexico, a Robert Wood Johnson Health and Policy Society Scholar at the University of Pennsylvania, and recipient of the 2007 Investigator Award in Health Policy Research from the Robert Wood Johnson Foundation. In addition to all that he's done for us on INQRI, he also serves as a member of the National Advisory Committee for the Robert Wood Johnson Health and Society Scholars Program. Jose has been an unbelievably, incredibly active member of our National Advisory Committee from the outset, and we thank him for his service and for leading our session today. Jose, let me turn it over to you.
Thank you, Mary. This project today is one of the first studies of implementing the implementing and translating the transitional care model for individuals with serious mental illness. And today we have two presenters. We have Nancy Hanrahan. She's Associate Professor at the School of Nursing at the University of Pennsylvania, and Phyllis Solomon, Professor in the School of Social Policy and Practice at the University of Pennsylvania. So what we'll do is I'll pass it on to Nancy now, and then towards the end we'll have a question and answer session, okay? Nancy?
Okay, very good. Since the Affordable Care Act in 2010, interest has grown in people that have, or the population that has serious mental illness, because they are a high-need, high-cost population. This population is quite vulnerable in that it's known now that they die 25 years earlier than the general population from treatable, preventable illnesses, and that they have a high degree or a high number of medical comorbidities. For instance, they have heart disease. They're 3.4 times more likely to die from heart disease than the general population, and 5 times more likely to die from respiratory ailments. So seeking an intervention that specifically addressed their transition from hospital to home made a lot of sense. And we hypothesized that with translating the transitional care model developed by Mary Naylor and her research team at the University of Pennsylvania made a lot of sense. And we set the study up to do just that.
We decided to test the evidence-based model, the transitional care model, in this population. It had not had limited testing up until that point. And we hypothesized that although the evidence of costly cycling in and out of the hospital, and we're talking between 30 to 50% of readmission rates, that the high cost in this period of shrinking healthcare resources, it made sense to try to prevent rehospitalizations and utilization of the emergency rooms by providing a service, the transitional care services. So there's other things about this population that need to be known in the context. Mental health problems lead to poor navigation of the health system because the population are not able to engage and motivate. Their decision-making may be slowed, and they have a poor memory sometimes, and a lot of that is not only the mental illness but the drugs they take. And we know that about a third have poor literacy, health literacy, meaning they cannot process the information that they receive very easily. At the system level, we've got these silos of systems where mental health and health care and substance abuse are very difficult to maneuver and navigate. So the purpose of our study was to answer the following questions, primarily to answer the second question. In this presentation, we're going to be speaking more to, is it feasible to implement and modify transitional care model for discharged patients with serious mental illness, and what are the barriers and facilitators to implementing and sustaining the model. And this was an 18-month project. So the transitional care model developed by Naylor et al. Emphasizes educating patients and family caregivers to address root causes of poor outcomes and avoid preventable hospitalizations. The essential elements of transitional care is an advanced practice nurse who primarily coordinates care and directly provides care to assure that there's consistency across episodes. In-hospital assessment and a plan of care. The advanced practice nurse visits does home visits, and telephone support is available 7 days a week for 90 days or 3 months. Continuity of medical care between hospital and primary care physician is facilitated by an advanced practice nurse accompanying patients to follow-up visits with physicians.
Hi, this is Phyllis Solomon now. I'm going to give some of the background literature with regard to this. Public health nurses working with people with severe mental illness, transitioning from hospitals to the community is not new. In the 1960s, when a number of hospitals were closing, there was a large study that was done in Lexington, Kentucky, where they provided transitional care from state psychiatric facilities to the communities, and they were successful in providing them care where they were maintained in the community. More recently, ForCheck in Canada developed a transitional discharge model for psychiatric patients being released from acute care hospitals, and that was then replicated in a smaller scale in Scotland. The transitional discharge model that she used included a peer support and nurses from the hospital to transition and work with clients till they made a good connection with community providers. And so this could last anywhere from, if people went back to their prior providers, it might be a short intervention for the nurse from the hospital. But if it was a longer term, it could go up to 12 months, but on average, they found it took about 3 months to transition. She also had a peer support portion in which she helped people to develop a social network. And that lasted a year. There were 2 RCTs done, one small scale in Scotland, where they found reduced readmissions, reduced symptoms, and improved functioning. A larger scale study that was done, cluster randomized design in Canada, found that for the most part they didn't get any effective outcomes in terms of rehospitalization or emergency. But they did get improved social relationships, which made sense for the particular model. The other thing that they found was that it was an ad hoc finding, which was that they reduced the time in the hospital. That was one. Those were 2 other more recent studies in terms of it. There have been other transitional care models from hospital to community, and these are more social service oriented rather than health oriented. So one of the recent ones is CTI, which is critical time intervention. And that's a 9-month social service outreach kind of model that's similar to transitional care, but really deals just with the social service and housing aspects, because it deals with persons with severe mental illness who are usually also homeless. And here they found a reduction in hospitalization in a recent study that looked at those that were homeless but transitioning from the hospital to community integration. Another model of care that has also used nurses, that is used a lot with persons with severe mental illness, is assertive community treatment. This is a self-contained team that includes a psychiatrist, a nurse, case managers, a social worker, and other specialized interventionists, depending upon the population. This was then implemented recently in Japan, where they transitioned people from hospitals to the community, but it is an ongoing, high-intensive, it's not a transitional service model. So that's some of the background literature. Now we'll move into the methods. What we did was to have a small pilot RCT where we randomly assigned 40 clients, 20 to the transitional care model that we adapted, and the usual care. The psychiatric nurse practitioner intervention. She met with the clients prior to discharge from the hospital, immediately after discharge, in home visits, ongoing phone calls. She accompanied the clients to medical and mental health appointments, contacted medical and mental health providers to share information, and also assisted in medication management. It was a 3-month duration intervention. Another aspect of this was to have an ongoing advisory group of the major stakeholders, which were consumers, public administrators, nurses, doctors, those who were working on the inpatient unit in which we recruited our clients, and also we had insurance representatives. So they met with us monthly as we implemented the RCT to see the challenges and barriers, as well as the facilitators to implementing this model in the community with regard to persons with severe mental illness. So the eligibility for the randomized trial was people between 18 and 65 with a severe mental illness, those who had schizophrenia diagnosis, spectrum diagnosis, bipolar, or major affective disorders. In addition, the clients also had to have major medical problems such as diabetes, cardiovascular problems, cancer, etc. We recruited these clients from 2 inpatient psychiatric units from General Hospital in Philadelphia. The research associate who recruited for our study sat in on daily team meetings at the 2 inpatient units. These meetings included a psychiatrist, residents, nurses, discharged social worker, who then screened for eligible clients for the study in terms of looking at those who would be recently discharged from the unit. The outcomes we looked at were medical and psychiatric readmissions, emergency room use, and links to community mental health providers. We did content analysis of the advisory group meetings, as well as case studies that the nurse practitioner did for each of the clients on an ongoing basis, as well as statistical tests to look at the differences. Now I'm going to turn over for results to Nancy.
I'm going to go through the results fairly quickly. And just to preface it to say that there were no differences in demographic characteristics between the 2 groups. However, there was a lot of consistency too in our long-term association with this population, knowing that low income, the fact that there's very little support systems among these folks. Most are single. What's also interesting is that almost half of the participants were African American. Up to 40 to 55% had less than a high school education. Most lived in, a third lived in unstable housing, and we'll speak more to that later. And their diagnoses really essentially were equally distributed between mood disorders and psychosis. Psychosis, including schizophrenia, schizoaffective disorders, and psychosis not otherwise specified. They had complex medical and mental health problems, as we've seen in the literature. Most of it was 60 to 70% was associated with cardiovascular disease, high rates of respiratory illness and neurological disorders, et cetera. All this was consistent with what is known in the literature. Also consistent is that the groups had 2.5 to 3.6 additional medical comorbidities in addition to their psychiatric conditions. We looked at readmissions to the hospital and emergency service utilization and found that the control group had lower readmission rates than the intervention group, and the intervention group had lower utilization of the emergency rooms than the control group. We'll discuss that in a minute. And also, there was no difference between each of the groups. They actually are doing a good job around getting them set up with appointments while inpatient and then attending those appointments when they get out. So a successful case example of one of our clients was a female who had manic episode, had been hospitalized for that. She was also hypertensive. She had diabetes, rectal cancer, and a seizure disorder. She came from a very unsupported background, very few support family or significant others. She was completely overwhelmed with the medical appointments that she had been assigned while in the hospital. Apparently she had been diagnosed with rectal cancer just before she had gone into the hospital, and really had blocked that because the nurse talked about how when she got to the doctor's appointment, they went together, the patient was completely surprised by the idea that she had rectal cancer and had a major anxiety attack and breakdown, of which the advanced practice nurse intervened successfully with cognitive behavioral therapy and some other de-escalating interventions that are well known by psychiatric nurses. So the nurse intervention, she spent a lot of time on educating about medications, diagnosis and medications, coordinating care, prescription refills, recommendation of medications with primary care physicians, and accompanying this client to medical and psychiatric appointments. She also did a lot of coordinating of hospital admissions for chemotherapy and other appointments, and the complexity of managing and coordinating these across the two silos of mental health and medical health care was a significant part of her activity. This client responded very well with the support, as did her providers, who still call the nurse to try to get her involved in some other cases. The client did have her chemotherapy for her cancer. She was reconnected with a primary care physician who's following her very effectively, and she continues with an outpatient psychiatry, and she had no psychiatric hospitalizations. An unsuccessful case, and I'm going to speed it up here a little bit, was a male, Caucasian male, who was admitted for being physically aggressive in his boarding home. He had paranoid schizophrenia and traumatic brain injury. His cognitive impairment and thought disorders, and this is pretty typical of the clients we see, made it very difficult to establish a relationship with him, a therapeutic relationship, and his difficulties within his living situation was and often is an inability to respond appropriately to social cues. This particular boarding home, however, took some of the blame for how aggravated this client was. In fact, it eventually became unlicensed and eventually was shut down. Initial contact with the case manager, and this is another point that makes it successful or unsuccessful in these cases, they often do have case managers. But the case manager became less and less responsive to the nurse, which made it much more difficult to create an ongoing, sustainable plan for this client. This client also had difficulty sleeping at the boarding home, and the APN was able to prescribe a medication for a couple of nights, and he quieted and was able to manage his behavior. Often what happens is that the boarding home can't manage it, and they bring him to the ER, or brings people to the ER, and they won't prescribe because they don't know the case, and it's complicated. The outcome was that he was readmitted to the hospital because of the shutdown of the residence, and he was responding to the increased stress of his environment. While he went into the hospital, he became very aggressive. He was discharged but returned again the same day, and he was quite destabilized by the living situation event. So I'm going to pass this over to Dr. Solomon to talk about some of the other observations we made.
Hello, this is Phyllis. One of the things that we noted in this population is quite different from the usual populations that are treated by transitional care management, where modeled, because here the clients are not always receptive to the service. They have difficulty engaging. They often don't have family members who are a part of their life to help them with their care after release. And if they do, they often have a conflictual relationship with their families, and the nurse practitioner often had to handle these. And some of them don't live in family settings, but boarding homes, and she had to work with the boarding homes where people had conflicts with other residents and with the staff, where they were unwilling to deal with their medical problems, as was one patient who had a toe amputated and didn't want to return to the hospital to get the sutures removed, even though it had been about 3 months. So there are a lot of unstable housing situations with this population. We found that a good portion, almost a third of them, within the 90-day period moved. And they also had a lack of cooperation, receptivity, not necessarily to being receptive to the service of the transitional care. A number of them, they lacked recognition that they had any need for this service, and so it was rather problematic at the individual level. The other problem was at the systems level. What we found here is that whereby medical providers often were really receptive to the advanced practice nurse because they saw the kinds of things that she could help them with, such as the patient who got rather anxious in the doctor's office when hearing of her diagnosis. But where it came to mental health programs, they were not very receptive. They often would identify HIPAA as that they could not, it was confidential, they couldn't hear, they wouldn't listen to the fact that she was a service provider for the clients. They were afraid of liability issues, and they would not cooperate and provide information or even indicate whether a person was in their facility or not. There are 13 hospitals in this location which have psychiatric units, and a number of our patients would get admitted to any one of these. When she'd find out where they were, she would go to the hospital to try to connect with the patient so that she could try to reduce the length of stay there and help them transition back into the community. And most often she was stopped at the front gate and was told that due to HIPAA, we can neither confirm nor deny that this patient is in the facility. And so we understand that these things due to stigma, mental health, but it makes it very difficult for care. I turn it over to Nancy now.
So we're going to discuss now some of our
findings. We're going to discuss now some of our findings and discuss specifically more about some of the modifications we did to the original transitional care for this population. One modification was that we used a psychiatric nurse practitioner. A psychiatric nurse practitioner is an advanced practice nurse, which is not different from the original TCM model. But the psychiatric nurse has both education at the graduate level in integrated care, medical and psychiatric issues that are specific mostly to this population. The transitional care nurse practitioner assessed, diagnosed, and treated these physical and mental health complex needs of patients. She played a key role in translating and sharing information among both medical and mental health sectors when systems barriers did not make this possible. In the medical sector, the nurse practitioner was welcomed and valued as an asset to the treatment process. Medical providers were thrilled to have a knowledgeable person to understand and negotiate the needs of these folks. And they are generally not trained to manage conflict-ridden responses from patients, nor do they have the time or resources to address these unmet, complex psychosocial needs of patients with mental illness. With the transitional care psychiatric nurse can prescribe. She could write prescriptions for lost discharge prescriptions, which happened quite frequently, ensure that patients were taking newly prescribed medications, which also happened quite often, that the patient would go home and not understand the instructions from the hospital. And she could substitute medications that insurance would not cover and write new ones that addressed behavioral problems. For instance, she went to an appointment with one of the clients who was prescribed a medication in the hospital that was not covered by their insurance, and the nurse was able to suggest a substitute medication that would have the same effect or similar effect on the symptoms. Most importantly, the nurse was an ambassador for the patient, playing a key role in negotiating with and serving as a bridge among medical and mental health providers and systems. She translated information from patient to provider, from provider to patient, and from provider to provider. Recognizing the need for certain services, her role was to advocate for meeting such needs. In some instances, this may have meant actually returning to the hospital, and that is one of the explanations that we have for the higher rate of readmissions for the experimental group. One of the other observations we made is that we needed to modify our eligibility requirements. We initially set up the eligibility for patients that had a need for medical services, and we discussed very frequently throughout the study, what does that mean? Is that a health need? Do we use a diagnosis to determine whether somebody should be eligible for the study? And in the end, what we decided was that, given the response of patients, because patients that did not feel like or interpret them as needing somebody to help them with their health, we believe that the best way is to have patients who can fulfill these questions. Does the patient have an active health need that is not being addressed? If so, can this health need be significantly addressed, managed, and impacted within the 90 days of transitional care? And the other question was, is transitional care likely to improve the outcome? An example specifically was we had a patient referred to us who was 7 months pregnant, and she had schizophrenia, and we did not accept her into the study because she did not have a medical diagnosis. But we knew that this was a patient that could use a 3-month follow-up with an advanced practice nurse very effectively. So some of the issues that arose from the as we observed from the transitional care implementation with this population, is that the time to develop an alliance was much longer than most patients. And there were relational conflicts with informal caregivers that were very characteristic of most of our clients. They also had serious unmet basic needs for housing, enough money for food, enough transportation, and just basically having supports in their lives that gave them what they needed. And there is the poor communication and coordination among siloed systems, the healthcare system and the mental health care system, the substance abuse system, is a major navigation nightmare for this population. And now I'm going to pass this on to Dr. Solomon to finish up.
So one of the things we found was that TCare, our transitional care model, worked best for persons with an acute medical condition. So what we felt is that we'd like to do another study where we recruit from the acute medical units, as was more the case with the original model, rather than from the psychiatric units. Here we feel people will have more of a pressing need for medical care, recognize that need, and be more receptive to the service. The other thing is that we think we'll reduce the length of time in the hospital because what we found was when we talked with people from the Consultation and Liaison Service of Psychiatry and asked about recruiting in the medical side and what their interest was and if this would make a feasible kind of approach, they were delighted by the idea and want to know how soon we were going to start doing it, because what happens is often these patients stay in the hospital longer because they know that they can't find an appropriate housing setting afterwards that can handle the medical problem. So then the other thing we feel that we need to move on is to look at the program, more of a team approach to the model. And I'm getting confused with which ones I'm looking. Excuse me a second. Okay, yeah. So one of the recommendations we feel that was apparent through the implementation of this was that the nurse practitioner was very good at handling the medical problems and could really facilitate that, but that so many of the psychosocial needs and social needs in terms of housing would be better served by having a social worker work with her, that her time would be better spent on focusing on the medical issues where she has the expertise and using a social worker in terms of the psychosocial. The other member of the team that we'd like to see is a peer support person that can help with the alliance and the and helping them develop other support mechanisms for them so that they can be more integrated into the community after the 90-day period is up. And then we'd like to, we still feel that there needs to be a psychiatrist that would provide consultation and supervision. So we see it as a team approach, kind of combining the CTI, critical time intervention that I mentioned previously, and merging it with the with the nurse practitioner model. And finally, we would like to do another pilot study where we would recruit people, participants not only from the psychiatric side, but also from the medical side as well. and really ask the kinds of questions we ask of who would benefit rather than looking at just medical disorders, but look at people with more acute medical needs and and spend more time up front in the hospital meeting with these clients, not the short amount of time that we did, but lengthening that time in order to create a better alliance.
So that was our study, and we are open for questions.
Thank you, Nancy and Phyllis. I think you mentioned something about differences in readmission rates between the intervention and control group.
Yes.
And also in ER visits. And I guess I know the sample size is small, but can you talk a little bit about that? About what do you think drives those differences?
Yes. It actually makes sense when you think of when we thought it through, and we thought this through and talked about it many times with our advisory group, that if you put a nurse to serve people that are so underserved, you're going to see an increase initially of the utilization of services. And we also considered that we were only measuring the effect of this intervention over a 90-day period, and that we believe that if we were to measure out 6 months to a year, that we would probably see have a better sense of how effective the transitional care intervention was in this population.
Thank you. And you know, when you look at the challenges of what are the challenges of implementing behavior management solutions under the transitional care model? And I ask that question because when you describe the intervention, you know, it was oriented more towards medication management than behavior management. And I know part of it is because of the focus on the psychiatric nurse practitioner. So what are the challenges of implementing behavior management under the model?
We found that there were major challenges. Most of this population is already served within the mental health system, and they have case managers assigned. Case managers are educated, if possible, at the baccalaureate level, but often are high school graduates that get minimal training. The patients do go and see a therapist when they become sicker, but in general they're not seen for any kind of behavioral management on a regular basis. They do see a psychiatrist for medication management, but the behavioral management, interestingly enough, is not well adopted, and people almost have to get better to get some of the recovery education interventions that really focus on life skills and building life skills in order to utilize them. And the population we were working with were quite sick. They had just come out of the hospital, and you know people do stabilize. They don't remain that ill. The nurses' education includes doing therapeutic interventions, including cognitive behavioral therapy, de-escalating aggression, and negotiating conflict. The psychodynamic therapy, or the therapist as you normally think about, is not what this population generally requires during an acute phase. It's more about keeping things de-escalated and being able to interpret any kind of potential stressors that might aggravate the individual, and while continuing to try to keep them stabilized. Does that answer your question?
Yeah, exactly.
Okay.
Yeah, great, thanks. I have a couple other questions, but before let me just open it up to see if anybody else has any questions.
Yes, if you would like to ask a question, please signal by pressing star 1 on your telephone keypad. If you are using a speakerphone, please be sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on your phone line will indicate when your line is open. Please state your name before posing your question. And again, that is star one if you would like to ask a question today.
Yeah, while participants press star one, I'll ask another one, which is, when some of the readmissions and ER visits were more on the medical side than the psychiatric side. So I wanted to ask you, how do you plan to address that when you do the larger project that you mentioned towards the end? The fact that many people, for example, ended up not many, but some ended up at the hospital more because of medical conditions than on the psychiatric side.
There was higher utilization of medical-oriented emergency rooms in the control group. We felt that was a good indicator that the advanced practice nurse was actually meeting a lot of the medical needs that the participants had. We also saw that and this is just directional because the numbers are very small in our study, the direction was towards a lower utilization of psychiatric emergency use, I believe.
Yeah, I was looking at the table you had, and on the prevention group.
Yeah, I've got it.
There were two on the medical, two readmissions on the medical side, and zero in the control group. But you're right on the emergency room side, it was the other way around.
Yes. Again, these numbers are really small, but we saw that both the psychiatric and the medical needs were probably being better met in the intervention group by the nurse. And there was a slight indication that the control group would utilize the emergency room more for both psych and medical problems. And none of these differences were significant.
This is Mary Naylor. Thanks, Nancy and Phyllis. This is great. I just have a comment, and maybe if you react to it. The challenges that you described in the way in which the system embraced the transitional care nurse, the advanced practice nurse, are actually pretty common, meaning they are part of what has challenged us in some of our earlier work and certainly in our translational work. And one of the ways in which we have found it's been critically important to address this and anticipate it is, one, we now have nurses who become essentially credentialed to be part of these systems. They go through a credentialing process to be viewed as a partner, just not someone coming into a hospital or a home care agency or wherever it is, but rather seen as part of. They're able to, open records and so on. So that, it's been one of the major challenges we observed early on, but we found how critically important the upfront work you need to have systems begin to see these nurses as partners in care. We also have spent a lot of time before every effort to try to figure out who might be the champions for this approach to care in each of these systems and bring them together along with other clinicians who may have had limited exposure. So when you talk about those system challenges, they really resonate with me, and I think that some of the strategies that we've learned painfully from failed earlier interventions might be helpful to you as you're moving forward.
Mary, I think those are great ideas, and I think that's what we learned, and I think you're absolutely right. One of the things we felt we didn't do was to try to make it known system-wide so that people knew about the service and would be receptive to it. And that was an error on our part. Even though we had the key players in it, none of them thought that, because we were only doing it at one hospital. And so that's one of the things we really learned. Because whereas I think on the medical side, people tend to go back to the same hospital, most of these patients go to any hospital where they think they'll get admitted sometimes.
Right.
So that makes it even harder. The other thing is, I think that a recent study that was done of 2,000 patients from the psych side and looked at whether they had access to records from the medical and psychiatric, they found that they reduced rehospitalization rates. And so some kind of communication system is something else we need to look at. In Canada, they've done a circle of care so that all providers are implied consent, and as long as you're a provider of a client. So I think we need to look at some of these things, and I think the things that we've learned from this are really issues that are going to come in the forefront right now with Affordable Care Act, and also the fact that there's been increased recognition of the medical problems for this population and the need for more integrated care. So whether we have to get release of information forms done in the hospital or some kinds of ways to begin to address these issues in a system-wide basis. I think we focus these interventions and think of them more on an individual level, and we need to see them as system changes as well.
Great. Thank you.
Mary, I'd just like to also add that we found that the advisory group was essential as we moved through the challenges during this study. We had the right people at the table discussing the right things. But as Phyllis said, we could go one step further.
Right.
Yeah, thank you.
Well, we can always do that. Yes, thank you.
Okay, any other questions?
No questions on the phone lines.
Okay. I think that's pretty much it. Thank you so much, Nancy and Phyllis and Mary.
Yes, thank you for this extraordinary contribution. I think that everywhere I go, people ask, how is it that we're going to focus on transitions in health and health care for seriously mentally ill people? And, this is, as your cases highlight, this is extraordinarily complex at multiple levels, patients and systems and communities. So I really congratulate you on plowing through and paving some paths here to help build on, but both for yourselves and other teams, investment in this work. So thank you very much.
And thank you, Mary, and the Robert Wood Johnson Foundation for funding this study and supporting us through this process.
That does conclude today's teleconference. We do thank you all for your participation.